We're going to go ahead and get started, everybody. Thank you all so very much for coming. We know that you could have been a whole bunch of other places at home or wherever on this beautiful evening, but isn't it great to have an 80-degree day finally? Dr. Zangari is going to speak today on myeloma and bone disease. So y'all, he's going to give you a lot of information. This is a great time for you to kind of kick back and relax and let him give you some information. And the great thing about these Meet the Myeloma centers is you get a chance to have your doctor here, and there's not a patient waiting to be seen. You know, he's not having to take phone calls and, you know, run over to the hospital for emergencies or to the lab. You got it. So use him. He's right here. He can't get away. I'll stand in front of the door. But it's a great time for question and answer. So y'all, Dr. Mauricio Zangari.
Okay. And good evening. Good evening. Good evening. So I'm gonna give you an overview of what we think is myeloma bone disease from our perspective and from the patient perspective, because it's important and it's becoming more and more evident that myeloma is really related to bone. It's not only a hematological disorder, but it's a bone disorder as well. So if you want to look at what is a bone composition, you can see that the main mineral is the hydroxyapatite. It's a big formula, but that's what the bone is made of. 90% is collagen, type 1, water, and other non-collagen proteins. So it's a big mixture of all these things that we have. And the bone is not something that is static, it's continuously formed and reabsorbed. It's actually in 1 year has been calculated that 10% of the bone mass is being replaced every single year, okay? And the cells that make the bone are all these cells, and you probably have learned to hear this name like osteoblast, which has the cells that make the bone, and osteoclast are the cells that reabsorb the bone, and there are many others, but basically is a continuous remodeling type of tissue. And here you can see what are the many important factors which affect the bone structure and bone longevity. If you look at the endocrine control, everybody knows if you receive steroids like we do all the time, and we give a lot of steroids on patients, you will have loss of bone. It's actually, in people receiving steroids, it's recommended to use biphosphonate automatically, because steroids, if you take for a long time, like our patient, they do for many years, they lose bone mass. Sex steroids and others tend to increase the bone mass, and there are other hormones like PTH, which is the parathyroid hormone, is a hormone released by the parathyroid gland that we have in the neck and has a lot to do with bone formation. Vitamin D is very important, and everybody, at least, we try to keep the vitamin D level at a certain level, because our patient, I can show you later, they tend to have low vitamin D for not good reason. There are also many other important aspects like lifestyle, exercise. Smoking seems to be associated with increased bone loss. Sun exposure is another good thing, because sun exposure creates the conversion of the active form of vitamin D, medication, diabetes, and so on. The bone development, there are two types of bone development. There is so-called intramembranous ossification, is a big name, but this is responsible for the formation of the flat bones, okay? Skull, spine, pelvis, they're all intramembranous ossification. Then there is endochondral ossification, other big words, but this is responsible mostly for the long bone, for the appendicular bone. If you want to learn a little bit more of this intramembranous ossification, basically the periosteum is a lining, is a membrane outside of our bone, is responsible for the formation of the bone, mostly on the skull, pelvis, scapula. Mesenchymal stem cells become osteoblasts, which is the main is the forming cells, okay, is the cells who makes this bone. and the osteoblasts produce matrix, and then they get mineralized. The endochondral ossification, on the other hand, comes from a cartilaginous model, and then it becomes ossified or mineralized at that level. Okay, so this is so-called bone-forming unit. This has been discovered many years ago, and is basically where everything happened. There are two types of cells: the osteoclast, the one on the left, which reabsorb the matrix and the collagen, and there are the blue cells, so-called the osteoblasts, which produce the new osteoid, the new bone. Okay, this is a big and very complicated system, which has a lot of control, especially from steroids, from hormones, and so on. And also, they are controlled by those cells on the bottom. If I have a thing, I can show you. Anyway, called osteocytes, which control the system. It's very complex, but at the end of the day, you will have reabsorption of the bone and formation of the bone. In a normal individuals, is well balanced. In myeloma, is not well balanced. Actually, there is an increased reabsorption and less formation. Okay. And this, if you want to take a look, we are inside of the bone remodeling unit. There is this canopy, which is basically the roof, and there are two types of cells: the purple cells on the left and the blue cells on the right. The purple cells, which is the osteoclast, start the reabsorption, okay, at one point, and is followed by the formation by the blue cells, the osteoblast. And they are released, the osteoclasts release this acid, hydrogen ions, which basically destroy the matrix. And you will start seeing these fibers, which is collagen. And the collagen is later also removed by collagenase and other enzymes. And that's the end product, if you can see on the left, before and after. So this is trabecular bone, okay? Is basically the basic structure of a vertebra. Beside the cortex, inside is like this, look like a sponge, okay? And due to this continuous absorption and formation, depends on the balance, you will have a stronger bone or a weaker bone. That's why, our patients usually tend to fracture on the lower thoracic and upper lumbar area, because all the weight is basically at that level. So if you want to look on a bone marrow, when we do all these bone marrows, the pathologist review basically this type of slides. The purple, the pink in the middle is the trabecular bone, and you see there are a lot of cells around. There are plasma cells. Let me see if I can find. Yeah, well, you can see very well. There are plasma cells. Okay, you can see here. All right. There are large cells. These are the famous osteoclasts, the one that reabsorb the bone. Here are all cells, so-called lining cells. They're osteoblasts, and these little cells in the middle of the bone are osteocytes, which are osteoblasts entrapped after the formation of the matrix. But what we see in a myeloma patient, as you can see, the surface is becoming irregular because there's been so much reabsorption at this level. You see, they go in. These are all plasma cells for your. So, and here probably you see even better how basically the mineralized bone has been reabsorbed. This is a classic. If you have a transformation from this type of tissue to this type of tissue, which is mostly collagen and a lot of cells, and this is all done by this imbalance between this osteoclast activity and osteoblast activity. And this, you can imagine that cause a lot of instability, a lot of fragility, and many fractures come from this, exactly from this type of process. I don't need to tell you, but multiple myeloma is about one new case for 15,000 individual per year. In the state of Arkansas, there are about 200 cases per year. There are about 3 million people here. Huh? Now, the 5-year survival, if you read on the in articles, is about 50% of 5 years. In this institution, is much higher. It's about 75% on the last thing that I saw. And the average survival improved with years because we have new drugs, a new ability to treat the patient and so on, much better supportive care as well. And then I'll give you this. This is the report. This was the original paper, which was published in 1975 by Dr. Dury and Solomon from Arizona, and they did the first clinical staging for multiple myeloma. Okay, after almost 40 years, we are still doing the same thing, and if you look, the stage was based on extent of bone lesion. Already at that time, they realized that the loss of bony mass was important for the patients. Hemoglobin level, if become anemic, and then serocalcium was important. A lot of patients, they have an increased calcium level because the effect of this continued and increased reabsorption. Okay, this now we call the CRAB criteria for treatment, but it's still used as indication to treat the patient. Okay, many centers, especially in the community oncology. In the community oncologists, that's what they use. They treat patients if you become anemic, if you have renal failure, or if you have lytic lesion and so on. So this still stands after more than 40 years. So why is this? Because again, in multiple myeloma, as I said, there is dysregulation. The dysregulation was always thought to be increased osteoclast activity, so more bone reabsorption, because many factors are being released by the myeloma cells, okay, like rank-Leiden or MMP1 and so on. But nevertheless, there has been more and more evident that myeloma cells, they do other things, and they affect the formation part of the bone, they affect the osteoblast function, okay? And here was published many years in the New England Journal, this DKK1 factor which has been released by the myeloma cells and blocks the differentiation of osteoblast, so they cannot make any more matrix, okay? So they block basically the production of the bone. So it's not only a distraction, increased distraction, but also decreased production, okay? So how do we look at bone disease in myeloma? Since many years in this institution has been used by MRI. This is type of MRI can give you different pictures. This is supposed to be a normal MRI on this sequence. Is T1 sequence. This sequence, what it does is suppress the fat. So basically, it will it will show you whether there is an increased content of water. Okay, and if you see here, for example, at this level, there is a white spot. This means that there is no fat. There is a lot of water. This is a focal lesion. Okay, that's what we call focal lesion. I will say how many focal lesions you had, and so on. It's basically a high concentration of water in one spot. We cannot tell you, well, we assume that this is myeloma, it could be something else, but this is what we see, okay? Or you can see all this uneven distribution is the distribution of water, okay? And this was one of the things that we started. As you can see, this was a long publication in 2007 because MRI here was introduced in 1998, 2000 already in this institution. And for example, in in the community oncology arena, is still required to do skeletal survey. Skeletal survey is good because it can tell you if you have a fracture, it can tell you if there is a lesion. But to see, for example, this focal lesion at this level, you don't see, okay? You can see with an MRI, it's much more sensitive, because to see a lytic lesion in a skeletal survey, you have to lose about 30 to 40% of the concentration of bone on that specific. Okay, if you have 10%, you don't see that. And these things, nevertheless, it doesn't mean that you have a lytic lesion hole. It means that you have a lot of cells in one spot, which with time usually end up in a lytic situation. Okay. Then PET scanning was introduced. PET scanning is a glucose, is a FDG glucose, which accumulates where there are a lot of cells which use glucose. So, and myeloma use a lot of glucose. As you can see, all these black spots indicate location of myeloma cells. And here there has been 3 scanning at different times. As you can see, correspondingly the M protein, the monoclonal protein that we look for in the blood, right? At the beginning, this was 2003, it was 7 grams, and then it started dropping down, then it went to 0, and this is the corresponding PET scanning. When there was a lot of production of this M protein monoclonal, then with time went down, and then it normalized on this particular patient, okay? So that's what we're trying to see. There are patients that can have all this evidence of abnormal uptake, but they don't produce protein. We call non-secreting. So there's sometimes you cannot have this correlation, but most of the patients, they have a correlating paraprotein. And then, for example, look, this vertebra seems to be normal. By PET scanning, has a focal lesion. When you do a CT, which is CT PET, you will see that this is the vertebra has a big little lesion. So they lost a lot of bone there, okay, which correspond to this positive focal lesion by PET scanning, okay? So these are different ways that we can identify bone lesions. Now, in 2003, 2004, here, I saw this patient, because this came really from a patient experience. This was a 63 years old lady with a kappa HM myeloma, who relapsed after our usual tandem transplantation and total therapy. And at that time, we introduced bortezomib, which was a new drug for us. And there was these multi-center studies with bortezomib, the Valcade that we use now, right and left. And this was the dose that we gave, and that's what we noticed, and I noticed this. So the patient has a very high light chain. This was, I think, was a couple. Anyway, more than 6 grams of protein, which is this blue line, okay, was very, very high. But at the same time, we noticed these strange things. So the alkaline phosphatase, which is an enzyme that is in the blood, is produced by different organs, was astronomically high, was 1500 international unit. Usually it's about here, 75 to 95, something like that. And the level of the alkaline phosphatase was invertedly correlated with the levels of this protein, the paraprotein. As a matter of fact, when we start treating the patient with this bortezomib, the alkaline phosphatase went up. At the same time, my best guess at the time was there was another fracture, because when you have fracture, alkaline phosphatase comes out from the bone. But that was not the real story. The story was that these patients start to make bone, produce bone, and at the same time, when it was very high, the paraprotein level went down to 0. And it was interesting to see that this paraprotein remained very low for a long time until the alkaline phosphatase enzymes decrease, and when we come below what it was, the paraprotein came back, so myeloma came back. So we saw an inverse correlation between the level of the alkaline phosphatase and the level of the paraprotein in these patients. So that's what I did. I called the company and I got all the data from these two big studies that they were conducting, the Summing and the EPICS and so on. And what I did, they were so nice to give me the data and to check the level of alkaline phosphatase in patients who responded to Velcade and patients did not. And they confirmed the idea that an increase in alkaline phosphatase was associated with a response to the disease. This was the first, probably, report of this type of association. So it was confirming the fact that bone formation is not good for myeloma. Myeloma doesn't like your bone if it gets formed, okay? So the next step, and this was a really very nice group of patients on ours. So we tried to look prospectively on patients with myeloma. What was the effect of this drug as a single agent? And we used different dosages. We started with a 1.3 milligram per meter square, which was given day 1, 4, 8, and 11, which was the old schedule that we used for many years, every 21 years, and every 21 days. And we tried to decrease the dose of bortezomib. We start with a few patients with a 1.3, then we go 1 patient, and so on. And then we measure whatever we could measure, try to understand what was the mechanism of this type of phenomenon. We measure PTH, which is a hormone, it's a parathyroid hormones, osteocalcin, calcium, magnesium, phosphorus, and so on. And these are the patients, there are 16 patients were enrolled in the study. Median age was 63, 7 male and 10 female, evidently. No, 9 females. And they were all nice to us because they agreed to have a bone marrow, which was done in the operating room by a very nice surgeon who was getting a cortex to cortex sample. So the usual bone marrow when that we get is you get the cortex, but you don't go all the way through the bone. In this case, we got basically the entire thickness of the bone. This was done in general anesthesia and operating room. And we did our study, so we were looking for this, basically what happened to the bone formation. So this is the pre-bortezomib picture. And as you can see, these red lines are called osteoid, which is the matrix produced by the osteoblast on the same patient before and after. As you can see that the thickness of the forming of the matrix was significantly different, that you can see also here, okay? And so we proved that that was the mechanism. So there was an anabolic, so-called anabolic effect of bortezomib. And also they were so nice that when we get the core biopsy, as you see, cortex to cortex, and by micro-CT they can calculate how much bone is there. So if you do bone volume over total volume in this particular patient, a baseline, it came back at 12%, post was 90%. And this is basically after 3 cycles, 21 days, 2 months. By the way, this patient is still with us, and we still remember those days. Anyway, but it was pretty clear that there was a much bone formation in the responding patient. If you use bortezomib single agent, not everybody respond. At that time, I was at 30 to 40% at least. But in a responding patient, that's what you see. So, and then after 14 years, we start looking what we have done to this patient in terms of bone. And because we noticed that some pelvic lytic lesions, very large lesions, they were healing. So we start looking, for example, and then we published recently this, if you want to look, you can look, but we look at remineralization, basically. So these are healing lytic lesions, percentage of healing lytic lesions in patients that are being treated in total therapy, okay? So these are the study which was done was a total therapy 4. I don't know if you're familiar. This is a total therapy has been applied to patients so-called low risk based on GEP studies. And we review 62 patients. They were found to have a lytic pelvic lesion at least larger than 1 centimeter, okay? Because just to see, you need at least 1 centimeter for the radiologist can tell you if they're healing or not, okay? And what they did, the radiologist, they were so nice, and they look at PET studies, and because the PET scan, it has a CT portion, so you get the CT portion and the PET scan, and see what was the change in the size of this lesion. And this is the inclusion criteria for the TT4. I don't know if you have been involved in the TT4. So these are newly diagnosed patients who come to this institution who has a GEP risk, which is our gene expression profile less than 0.06, which has been we define as a low risk. And then this is the schema. Probably I don't know if you're interested, but anyway, this is basically the patient on TT4 receive an induction with MVD-PACE times 2 transplant 1 and transplant 2 consolidation, then they go on maintenance for 3 years. All right? So it's usually our backbone that we have done for many years. If you want to know what the survival on this type of intervention, so the survival on TT4 is probably, you can see that 50% of patients are still alive and is projected to be on 15 years. So it means if you have a low risk type of disease and you go through this type of intervention, you will have a probability 50% to be alive 15 years down the road, okay? Which is, I don't think there is any protocol can come close to this that I know of. So the lytic lesion that they were identified, so bony focal lesion defined as a lytic area measuring more than 1 centimeter because the radiologist could not otherwise clearly define an improvement. They are measuring the CT portion of the PET, so this is CT scanning. The remineralization is defined as sclerotic change in the lytic lesions. Then I'll give you some examples. And they use usually the plane, so they used to, they find the plane where it has the largest dimension, okay, on that particular lesion. So, doing this type of analysis, they found 233 patients, 144 males, 89 females. This was the range. And the healing, to tell you how much do you heal, they measure the initial size minus the final size divided. They give you just a number, basically. And that's what we found. So out of these 200, how many were? More than 200 patients, 86 patients, we didn't see any significant change in the size of the lesions, but in 137, whatever it is, 110, 29, 34, 47, okay? The majority of patients, we have noticed, they have noticed a change in the lytic component, so the holes start to fill up, okay? And then you have complete healing, 13, 5, they were 75 or more, and so on. So basically showing that if you go through this type of intervention, there is a probably 2/3 chance to have this big lesion to heal, okay? And this is important for many patients who has a lot of bone loss. And if you look at the distribution, the majority has pelvic lesions, okay? I don't know why, but it seems to be the site with most type of large lytic lesions, so we know, and I'll show you some. Then the spine, sternum, ribs, scapula, skull, these are all flat bones, okay? In the in the distal, on the arms and legs, there were a very small percentage. Usually, myeloma doesn't go to the appendicular bones just late. Usually when patients with time, sometimes they show up, but usually at the beginning there is not much involvement of this type of bones. And just to give you some example, this is a pelvic lesion, left iliac, you see this hole, and this, as you can see, there is a healing. This was basically loss of matrix or mineralization, and here you can see the remineralized back, okay? Just to show that, because it was always being the idea that if you have a lytic lesion in myeloma, they don't heal, but it's not correct. It's actually, they, at least with our intervention, they really, they heal. And for example, look at this one. This one is this was a lesion coming out from the ribs that you don't see anymore here, the ribs. This is the right fourth rib lesions. After treatment, the ribs reappear. This is not a normal bone, but it's really remineralized, okay? So the bones come back. And this is an example of manubrial lesion, is a lesion from the sternum. As you can see, there was demineralized all over here, and then look how nicely it comes back. So these are all examples of the same phenomenon. And this is one of the lesion on the skull. Again, you don't see the skull here, you can start seeing back again. These are probably the biggest collection of this type of analysis done in the world. It's not published yet, so you see things before. Anyway, they come for our patients, and we probably will publish shortly. If you want to see the time when you start to see this type of healing, here this is an example. This is a patient who came, the presentation, pre-treatment, following after stem cell transplant, so it's 3 months after, more or less, as you can see, from a complete demineralized situation. You go back to here, where you can see the periostome. All right? And this is after 3 years, okay? So, and then when you have something like this, the functionality of the patient significantly improve because they go back walking and doing what they have to do. Now, we have also patients, as you know, so-called high risk. High risk, we have done the same exercise to look if TT5 or patients with the high risk patients, they have the same response, okay? In the enrollment for TT5 patients, you need to have a GEP more than 0.66. This is a gene expression profile, okay? And this is, again, that's the schema, again, but more or less is the same. There are some drugs changed, but there is an induction, a transplant phase, and maintenance, okay? Again, this is the same criteria that were used for the TT4 patients. And then we found 95 patients on TT5, 29 were excluded because the radiology could not measure basically, or because there was the CT scan was not there at the beginning, or the exam was not appropriate, and so on. But the remaining, there were 66 patients that were analyzed. And again, largest, they took one focal lesion per patient, the largest, so they can see the mechanism basically. Here we go. So out of the 60 patients, whatever it was, there were 17 patients didn't see any change in mineralization at the site of the focal lesion, but these are 47. Again, they were able to tell us that there has been healing of some degree. 15 heal 75 to 100%, so it's significant, and so on. So again, telling us that you can have remineralization and healing of this lytic lesion in low risk patient or high risk patient. Okay, so basically everybody more or less behave the same. Now, 2 words, I don't want to keep it, but 2 words. What other things we can do beside the treatment, okay? One of the things that we like to do for our patient is to keep an adequate level of vitamin D. Vitamin D, if you read, has a lot of ability, as being shown. There's been some suggestion that is good in breast and other cancer. It's working on the kidneys. It works on the parathyroid, bone and intestine, and so on. There's a lot of good things. Vitamin D, unfortunately, in our patient, seems to be low. This is a US population. Sufficient vitamin D levels found in 70%, insufficiencies in 24%, and deficiency is 8%. Deficiency by this type of measurement was less than 20 nanogram per ml. Okay? Look at this is my clinic, we measured 220, now we have probably many more. But the sufficient level from 68 to 30%, insufficiency from 24 to 32, and deficiency is 38%. And this is easy to fix because you just take the pills. We usually recommend 2,000 units of D3 or 5,000 D2 and so on. But you can easily, and even because that if you have a low vitamin D, your PTH level goes up, and the PTH level at high level and remain stable for high level can increase the reabsorption. So it's better to keep the PTH down. Now, the other thing that everybody probably knows, we use biphosphonate. This is the recommendation for use of biphosphonate from the ASCO. Not that we follow much, but at least they finally agree that for patients with multiple myeloma on therapy, with or without lytic destruction, so you don't need to have lytic lesions. And then probably because many of their patients are still using skeletal survey, they recommend Aridia, Ozometa, right, on monthly basis. Nowadays there are also another drug called the Nosumab, which blocks one of the rank ligand antibody. It works very well. It's a subcutaneous injection. It's monthly. It's the same. How long do you treat? We were used to treat everybody forever. And then we found a lot of ONJ. There is osteonecrosis of the jaw. The ONJ problem has been basically, I don't say completely resolved, but is resolved for the most part because now patients, when they go to the dentist, the dentist asks them if they are on biphosphonate. And usually they don't try to work on the bone if they're on biphosphonate because they have problem, our patient, to heal, all right? And then nobody knows what to do, but we try to avoid biphosphonate use for a few months before, a few months after. We never seen major problem, but it can still come, but it's very, very low. And if you stop the treatment with biphosphonate, you can also restart if the patient relapses. Now, again, biphosphonate should be given patient multiple myeloma also with osteopenia, osteoporosis. We know radiologic evidence of lytic lesion. This is important because, as I showed you before, no matter what, if you see or if you don't see, the clone, the myeloma clone, keep producing and increase reabsorption. So you're going to lose, even if an osteoporotic, you become osteopenic and so on. So you try to block this type of process, okay? If a patient has benign monoclonal gammopathy, they don't recommend unless you don't have osteopenia, osteoporosis, okay? And to do this, you need to do a FRAX or to do a bone density, okay? Again, for 2 years, at least for 2 years, we use much more than this. And a couple of words, a patient with lytic lesion, many times we do what we call kyphoplasty. This is the procedure. If you see that this vertebra is starting to become weaker, and this one too. So what they do, our interventional radiologists, they put a needle, they go in, and they fill up what we call cement, and they become much more stable. We try to prevent fractures because when you lose the height of the vertebra, they start to have pain. We have seen patients that they lost several inches in 1 month, okay, because continuous fracture one after the other. So we try to avoid that as well. And then what the last two slides I'll show you. This is a patient who was, as you can see here, they have loss of the pelvic of the sacrum. This is a big hole before a diagnosis, and this is the report after 3 years. So he has completely rebuilt the bone. Anatomically, it's interesting because anatomically it seems to be very similar to the counterpart. And the question is, why did they do that? And then when I came back here 5-6 years ago, I was talking to the orthopedics, to the vascular surgeon, to the neurosurgeon. Yeah, because what is in here is not there is a hole, there is no mineralization, but there is a big matrix, and if you go to the operating room, you will see this big purple material, which after mineralization basically is able to reconstitute an anatomical functional bone. So, in summary, the myeloma bone is a big, for me, is a big field. It's getting more and more evident that the bone is a controller of the myeloma. When you solve the myeloma disease, the bone comes back. And there's also a good chance if you fix the bone, the myeloma goes away. But this is for the future. So this is my last slide. If you have any question, just, okay.
That was the last slide?
Oh, yeah.
Thank you, Dr. Zangari. Anybody have questions about bone disease or anything Dr. Zangari presented, or? Yes. Turn it on.
Yes.
Lori Fuentes, I'm a caregiver. My husband's off-Somata at the moment, but we opted to do just an annual treatment. I know that's kind of out of the realm of, what the Institute would recommend, but I just thought your thoughts on it.
So your husband is on annual biphosphonate?
No, we were thinking of just doing it once a year, one treatment a year.
Is your husband a newly diagnosed or?
No, 10 years.
10 years. Oh, okay. So my trick is we do bone density. You do bone density serum.
Well, I don't think we've done one in a while here.
But in my clinic they get religiously. But if you do bone density, you will have an idea how is the bone is going. So usually bone density on treatment we do every year or every other year. But if you do every year, you will have an idea. Bone density is a little X-ray. It has 1/10 of radiation compared to a chest X-ray. So it's a very little thing. And when you do, they can really give you an idea what the density of the bone at different sites.
Okay.
And if it's fine, it's fine.
Gotcha.
If you start losing, then you can change accordingly. Yes.
Okay, thank you.
Sure.
I've been using the Darotuzumab,
Yeah.
and I think, I guess, going on. It was, you start off every week, then it breaks on down. I've been doing it once a month for over a year now. And I seem to be on a dead level. I was trying to remember the one you was talking about, Benza, start with the B.
Vancate.
Okay, is that like a new drug there?
No, it's an old drug.
Okay, because I know the Darotuzumab, that's like.
And Darotuzumab is
It seems to be doing well. But I was just curious, like, I've been coming here for quite a while. When I came, started 11 years ago, still went here. And it was really a low living, as far as you're living, long-term was a very low rate.
Mhm.
And that was in 2008 and 2007.
Uh-huh.
Breakthroughs were made. And I went through a lot of the trial stuff. That's what saved. I was
Which trial?
shape.
You know?
Well, I had 14 of the fractures in my back and so
Yeah.
I was just curious about the daratumumab. And
Daratumumab, I never.
over a bigger rate than just one. See, where I'm from, it was like 2 people in 20 years had this disease 12 years ago.
Uh-huh.
And now it's like, it's pretty common there now because of y'all here, because people, a few of us from here brought it home, and thank God they using y'all's method here instead of somebody else's, because everybody's better there. And I was just curious about the daratumumab.
What?
That seems to be the going drug now, right?
Well, Mo is TT3,
Huh?
most, former TT3, right?
Yeah.
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 You
I
were
was in pretty
TT3.
bad shape.
Yes.
Yeah, but the TT7 also has the DARA in it as well.
And it seems to
Sure,
be.
yes, that.
I'm having the wells
What
for
is the
side
what
effects.
is the question?
I was wondering, does that sound like, I was looking at this, and this seems like a different drug you use, and everything sounds real good with it. But I guess my question is, the daratumumab, I didn't hear you come about it, any is comparing this to that, is that like a good drug?
So, these were patients treated with TT4 and TT5,
Mhm.
and they received whatever is in the cocktails,
They
right?
came after you.
Yeah, they came after you. You were on TT3, huh?
I'm not, when I was so sick, I'm not exactly sure.
So if you were on TT3, you received Valkay, Revlimid, and Dex
Yeah,
for 2-3 years, which is this drug.
I've had a lot of, like, I guess, relapse.
Yeah. Well, I mean, the percentage. There is
Yeah, I've been doing
a,
real well the last several years.
yeah. Daratumumab. If you want to know what that daratumumab done on the bone, it works like more like pamidronate. It blocks the osteoclast, seems like. But it doesn't do much on bone formation that I know.
Well, I guess I'm
But,
still
but
learning.
it doesn't mean anything. It's still, if you block the reabsorption, you still have some bone formation. If you block completely, you give time to the production to pick it up, you know. But I don't know if he has a very good activity on bone formation. I don't
Well, I
know.
think everything you're saying is good, because when Mo came in, he was almost crawling. And
Well, I was
so,
almost barely.
yeah.
Yes.
Yeah. so-
And then when did you start walk again? After how long?
5 months.
5 months.
5
So
months
you went
from
on
initial-
TT3, you got all this,
Yeah.
exactly what,
And that was 10 years ago.
and
Mhm.
But actually, he had a mass on his neck, and
Yeah,
after
so
we
I
did
have
the
the
red
cage and
devil,
all right now.
he did the red devil for 24 hours and it shrunk half.
sure,
And then he was able to use his arms and legs again. Because
Sure.
all that had shut down, it was really frightening.
Yeah, yeah.
We
That's
learned a
the,
lot.
yeah, yeah.
So I guess, and maybe this might help to answer your question. So your studies are with Velcade. So after the initial treatment and you're going on maintenance therapy, Velcade is not always part of your maintenance therapy. So the question is, if you want to continue to have a decrease in your lymphatic lesions, is DARA or some of these other drugs, do they have the same efficacy, or should Velcade be part of the?
I don't know. There are maintenance, for us is a new thing. So we do TT7 on their maintenance. We have used daratumumab here mostly in relapse patient. We have protocol with TT7, which now we are using on the upfront and use throughout the protocol. So I don't have much, but whatever I have spoken to other physicians, it seems more to have an activity, as I said, as a blocking osteoclast more than anything else, if it does. But I don't know. We never look. Probably with TT7 we'll have some idea that is still early for us.
Isn't the absence of myeloma in treatment, whether it's Velcade or daratumumab or Pomalyst or whatever, isn't that what also promotes healing and bone health in general?
Oh, this is a good question. All right. So this was the first question. When we found out that the Velcade responsive patient, they were the one who has this bone formation, we even look at patients who respond, for example, to dexamethasone,
Right?
and we didn't see that much bone formation.
Really?
But, okay, but that's what we did. We didn't do much. But there are, probably it will help. Certainly if you, whatever you do, you kill the clone, and the clone does those things, there should be some formation, there is no question about. If it does at the same level of this one, and seems to be even a class action of this drug, even carfilzomib, I didn't show, but we have the same, I look immediately, carfilzomib does exactly the same. Increase the alkaline phosphatase and bone formation. This is probably typical of these proteasome inhibitors type of drugs.
And also, what about people with MRD? Do you know if their bone health gets better? Because, you know, more and more people with some MRD are living quite well, have a good quality of life.
So MRD positivity.
Yes. You know, they never fully get into remission,
Uh-huh.
but
they live
they're
long.
doing well.
Oh, sure.
Yeah. Do their bones get healthier too?
Probably, my guess would be yes.
I mean,
but
a lot of them are
I never
Velcade.
look at the MRD and bone disease.
Yeah.
Because usually, whatever, you see, when you see this massive improvement, it's at the beginning, 2-3 months, so I can guarantee you they're still MRD positive. It would be interesting to look at those. Oh, God, that'd be
Yeah, because a lot of people I know with MRD are on Velcade as part of their maintenance therapy, and
Yeah.
it's, you know, used to be remission was, you know, the end-all be-all, and now they're finding quite a few people with MRD
so,
doing well.
The lady that I know has the longest myeloma, she's 36 years out, and she still has half a gram of paraprotein. Okay?
So,
No,
yeah.
it is a balance. I mean, my opinion is a balance, is the balance between the clone and what the bone can do. If the bone can hold this type of little growth, they can stay together for a long time. If the bone doesn't work well in terms of what it's supposed to do, then the clone pick it up, basically.
And then, hopefully, one final question, I don't mean to monopolize, but what about women in particular, since women are predisposed genetically for osteoporosis, period? You know, once we get into menopause, we start losing bone density and all of that, and when you're dealing with multiple myeloma on top of that with women in particular, are you seeing anything of interest there?
Women are always stronger than men, you know?
Okay, that's it, y'all.
There's no question they live longer with the myeloma, I mean, even if they have osteoporosis.
Interesting.
We have, you know, we have 200-300 patients, it's difficult to.
Well, I'm thinking if they're getting some Zometa, that's probably, or bisphosphonate, that probably helps to counteract all of that.
Sure.
Yeah.
If you do, we have done a study with fracs. I don't know if you know what the fracs are. You go in the computer, put fracs. You put age, weight, and which is prediction, is a system. We predict fractures for osteoporosis. You can do on computer, put fracs. And we noticed that the survival, we published that on patients with high fracs is lower compared to patients with abnormal fracs. So there is a lot of correlation integrity between the bone forming the osteoporosis and this disease. Is really a close interaction. Really. Myeloma doesn't like bone growing. Yes, if in kids it doesn't exist. Children, they don't have myeloma. They have some plasmacytoma here and there, but they don't, because they have a very high alkaline phosphatase, very high turnover. And when you become older and the turnover goes down, myeloma pops up. That's mine. Yes, that's what we're trying to convince people. They think it's a hematological disorder, but
This might be
it's
kind
more
of
than
off to
that.
the side too, but like with the Velcade, and I think that was one of my, worked well for the disease.
Yes.
But you gave me the neuropathy.
Oh, yeah.
And that was really the main one. That was the new ones, the Dorsa.
It doesn't do it.
I don't seem to have as much trouble with it, but that's kind of like, as far as making it worse with the neuropathy, has there been a study on that?
For Darzalex,
With the Dorsa. I know with the
we haven't
Velcade,
seen much neuropathy with
'cause I
Darzalex.
haven't had as much trouble. I know that the other was.
I haven't seen much,
really hard.
in my experience, I haven't seen much.
Well, I was
much
curious about
neuropathy.
that, because I knew it wasn't as bad on me. It seemed to be improving a little even, since I haven't been using that.
Yes, it's probably good improvement.
I was curious about that.
Okay. Oh, sorry, no.
Hello? I mean, okay, bye. That's my son.
So I know that there's, kind of a lot of people are hesitant to do exercise and physical activity or heavier physical activity because of the potentiality of, bone fractures. But muscles surrounding all of those bones are also going to support those bones. So I was wondering if you have had any type of recommendations about working with, musculoskeletal doctors and increasing the muscles around all of these, especially since the majority is the pelvic floor area.
We never studied these things, but certainly it's not a bad idea to keep moving. Keep moving.
Yeah.
We like our patients, they keep moving, they'll stay flat in the bed, like what they were used to be.
Pilates
It's
is
pretty
kind of
obvious.
this big thing.
Huh?
And Pilates is kind of this big thing coming up that's done a lot after rehab. For a lot of different patients in different areas that increases some of those muscles around those areas.
Oh, yeah.
That's a good question, because Dr. Barlow got asked him way back, because I was pretty active and don't look like it anymore. But what could I do, as far as what I'd hurt myself? And he pretty much told me if it starts hurting, stop doing it, but don't stop till it starts.
Yeah,
I
that's
said, well,
that's a good way.
I'm gonna do what I can.
It's a good way.
I
said,
have
I'm gonna do what
paranoid
I
sisters
can.
who
But
my
he
dad
never
loves
gave
a
me an
bicycle,
answer.
and I have paranoid sisters and a mother who are like, you cannot get on a bicycle. So,
Why is that?
so that's. So I was wondering about that physical activity and the fact that they're afraid he's gonna break a bone because his bones are fragile. So I was wondering if you could kind of speak to the
It
fragility.
depends on the patient, The young patients, they can do whatever they like. I have patients with big lesions like this one, and now he's back to doing I don't know how many miles on bicycle per week.
Yeah, Andy Siniski, I think, he rides all over the world for multiple myeloma on his bike.
That was
It's
a show that-
I don't think it's a contraindication there.
Be careful with falling. I was told to exercise, just be careful.
At what point would you recommend a person having kyphoplasty done? I have a compression fracture, and I've never had it done, but I'm thinking about it.
Well, if you start to see the fracture, first of all, the guy who decides is the interventional radiologist, but certainly we try to avoid fractures, because you lose height and you have back pain, we try to avoid mostly pain. If the pain, because what they can do, I show was just a kyphoplasty, but if you have, they can go in, drill it and expand with a balloon. So they try to reestablish the height of the vertebra and then they fill it up. And it's something, has been a long discussion and criticism of this type of procedure for osteoporosis. There has been big study published in the New England and so on. They said they didn't see any improvement. But in our population, works probably 80–90%. That's why in our, it depends, first of all, it depends who does, the experience that they have, If you have done 2,000 or 3,000, probably you're a good one to do these type of things, the indication and so on. If you go to someone who does 10 per year, you need to go to someone like, that's what he does, and he knows in which, because, for example, you need to be sure that the posterior wall of the vertebra is intact, because on the other side is the, the spinal cord. So and you cannot push too much. It's not that easy to go in, and they need to have some criteria to judge what they can do, what they cannot do.
Well,
But certainly when they do kyphoplasty nowadays, they can drill it open a little bit and then fill it up.
My last MRI, well, actually, my last two, when I first got diagnosed with myeloma, my MRI said that I had a compression fracture. My last MRI that I got, it said that my spine was starting to show some deterioration. And I was wondering if that was from me having a compression fracture in my spine.
Yeah, but did they do here?
I've never gotten it done. I have my MRI here, but my doctor never recommended that I should have kyphoplasty.
It depends, but do you have a fracture or not? They can,
The MRI said I did.
yeah,
I had
a fracture,
compression
but
fracture.
they can see if it's a recent fracture, an old fracture, based on the edema on the upper and lower end plate. The decision to do it is usually done by the neurointervention or the neurosurgeon, whoever does, because they are the one. I cannot tell them to do this and do that. Yeah, but we can recommend, and then they decide because they have the expertise on this particular, and they can tell you if they think it's beneficial or not. Because
So I guess I need to really ask my doctor to refer me to one of them, perhaps.
yeah, they can review. They just need to review the MRI downstairs, and if they review, they can tell you if they think they can help you. There is no 100% guarantee, but I would say 80% works, at least here, in our type of population, myeloma population.
I have a question.
Yeah.
This is my sister. So I've kind of like gone through this, but not really. It seems like I have, which when I came here with you guys, I don't think I've been through it maybe. But you know, our discussion has always been, it's been almost 3 years now, and I guess my question is directly. I've always encouraged her to have a bone specialist, and so my question is this, is it a good thing to have both the oncologist and the bone specialist too? Or another question would be, do you guys work together?
In this institution, I
In
mean, in this institution, there is a big bone group. They are specialized in osteoporosis. Usually for our patient, we deal with that. We have some unusual type of bone disease that we cannot recognize, that we send to them. They give us their expertise. But usually myeloma, bone disease, is handled by the hematologist, oncologist. Yeah, that's what. And then, you know, when we treat the patients, we gave, for example, Zometa monthly for 3 years. The bone guys, they will never do that. They do once a year or every 6 months. They are afraid of those type of things. We are really much more aggressive on this part. The treatment that our patient receives is external, much higher what is the regular standard treatment.
Any more questions? Okay, David?
Hi. So I've been in Little Rock since 2008.
2008.
Yes, TT4,
Yeah.
old TT4,
Uh-huh.
and just come for checkups and see how things are going. So I was curious, you were talking about vitamin D earlier as one of the things you should be taking going forward to protect for the future. Is that the primary vitamin that we should be looking at, or are there just a good range of vitamins that we should be taking?
No, vitamin D.
Yeah.
That's the one who is affecting the bone, okay?
So the lack of vitamin D.
Yes, and
Yeah.
usually, as I showed, the vast majority when they come here, they have low vitamin D. I never figured out why, but if you have low vitamin D, your PTH will go up, and to have a high PTH and stable high. So you can get PTH and to have bone formation, but the PTH that's been used for that is a spiking. So you get the shots, PTH goes up and come down. In that situation, you start to make bone. If you have a high PTH, right, and it stays high, like the people in renal failure, they lose bone. explanation is complicated and nobody knows exactly, but you need to be able to lower the PTH. Then it will still fluctuate. In normal individuals, PTH levels goes up at 10% 5 times per hour. And we spend a lot of money to figure it out. We can figure it out. But anyway, but it's nice, generally speaking, it's better to have a little higher vitamin D and lower PTH. Huh?
Okay, so
And it's easy, you take the pills.
you just take the pill, right?
Yeah.
But is that just looking at living with myeloma going forward, right? It's like, in terms of the vitamins that I should be focused on, is it just like a 1-a-day vitamin thing, or should I specialize and make sure that I get a higher concentration of one vitamin versus another?
Well, for what I know, the vitamin D is the real one. The D is important for bones. Huh? Bone is important to control the myeloma. Huh? Could be the other vitamin, I don't have the expertise on vitamin A or whatever. All our patients, they take a lot of vitamins.
Yeah, but do,
And I don't know what's the results of that. It could be good, but when I don't have data for that. The vitamin D seems to be.
Sometimes, and a lot of times, I should say, our patients come into us and they'll be on calcium with vitamin D. And you recommend that they take a vitamin D supplement, and they say, well, it's in my calcium, but it's really not enough. You should be taking a separate vitamin D.
and to avoid pills, because, you know, when you go through
Yeah.
myeloma and you've maybe been healthy your whole life, and all of a sudden you're having to take all these pills, it's very emotionally difficult. So I get a lot of things for him in liquid form, which also helps absorb better, because, you know, if you can't break down the vitamins in time for them to get into your system and stuff, so it's always, it gets to be kind of expensive, because you're always looking around for that better thing, but, so I was glad to see the vitamin D, because he kind of elbowed me, because I'm always saying, did you put some in your smoothie? Put some in your smoothie. But for him, I just make sure he gets a good core vitamin, and then some of these little extra things, you know, the alpha lipoic acid for peripheral neuropathy, and, you know, other stuff like that, yeah.
Or on the supplement thing, turmeric is another one that people like to.
No,
Curcumin.
Uh-huh.
Do you have like a recommended amount of curcumin that we should?
I don't think we have any recommended amount. A lot of patients, they take it. But I don't know if it helps, if it doesn't help, and then what it does. Yeah, I can tell you whatever, but it's not, has not been studied, at least here, we never studied this type of intervention.
Okay.
We gotta save time for the drawing now. Have more questions? I'm not saying we can't ask more, I just wanna make sure we get this drawing in. That's the fun part. Any more questions? Okay.